The broadcast is now starting. All attendees are in listen-only mode.
Well, hello, everyone. It's the top of the hour and time for our American Society of Cytopathology weekly education session. My name is Güliz Barkan from Loyola University, Chicago. I'm the president-elect of the ASC, and today we have a treat for you. We have Dr. Momin Siddiqui, who is currently a professor of pathology and laboratory medicine at the Weill Cornell in New York City. He is the director of the Papanicolaou laboratory at Cornell, and he also directs the fellowship there as well. He started his medical training in Pakistan Endowed University and did his residency at Loyola University, followed by fellowship in MD Anderson, UT Southwestern, and he worked at Johns Hopkins for a while too. And prior to Weill Cornell, he was at Emory University. He's a member of the executive board of the American Society of Cytopathology, and also has been a chapter leader for the American Society of Cytopathology and IIC Urine Cytology Terminology Task Force, the Paris system too. He has done numerous things for cytopathology and very well known in the cytopathology world. He is also on the editorial board of JASC, Acta Cytologica, Diagnostic Cytopathology, Cancer Cytopathology, and so forth. And today he will be teaching us about pancreatic cytopathology. So without further ado, here you have Dr. Momin Siddiqui from New York City.
Well, thank you for such a the environment we are all working in, both at work as well as outside in our everyday personal life. So given that, as you can see from this famous painting by Vinci, this should be actually the first order of business. Please separate and use whatever modality you need to use for meetings or for teachings, just like what we are doing here today for our session on pancreatic cytology. So what is my goal here? I'm sure you've all read the books, I read the chapters on pancreatic FNAs, but I want to share some of my real life cases with you. So that would be first and foremost. I'll definitely dwell into ancillary testing, go over some of the differentials and known pitfalls. But most of all, I want to also share with you what my operational layout of the service is and what clinical practices we perform over here to obtain our pancreatic fine needle aspirates along with other aspirations. So that might be of some use to everybody as well. So, but before we go forward, it's kind of, we need to know who we are. So I just want to do a poll, and Joanne, do you mind to just putting in the poll for us?
The poll has launched. Go ahead and respond. About 10 more seconds. I'm closing the poll. There are 35% are cytotechnologists, 25% resident pathology, 9% fellow pathology, 13% pathologist community-based, 18%
Excellent.
pathology.
I mean, that's really what I wanted to hear, because I think we have a very good mix here of both our cytotechnologists as well as trainees as well as practicing pathologists. So going to the basics, why do you do EUS and what we really get out of it. So the service actually moved away from radiology in most places, say in the 1990s, away from CT-guided procedures, which actually are still being done in some scenarios. But by and large, it's the gastroenterologists who manage this process for obtaining these samples. And the reason being is that they can go after smaller lesions. Lesions which can measure as small as 5 millimeters can be easily sampled by FNAs if it's done by EUS. In comparisons to, say, CT's scanning related procedures, along with obtaining a sample from the lesion itself in the pancreas, additional samples can be obtained from adjacent lymph nodes if staging is a question. If it's a pancreatic cyst, this is a great way to obtain cyst fluid, which can subsequently be sent to your clinical laboratories, or if need be, to be sent out for molecular studies. And lastly, acidic fluid can also be obtained so that we have serous fluid sampling and to rule out metastatic disease there if that's a consideration. So this is the background. So in our practice, our procedures are being done by rows, and rows, as you know, it's a collaboration plus a transaction. Why is a collaboration and a transaction? Because a cytotechnologist and a cytopathologist, they are both interfacing another service, which is the gastroenterologist. Their mission is to go in, do a quick procedure, obtain a sample, and give it to us and get an answer. But it all depends on the material they obtain. Of course, they're going to tell you I'm in the lesion, but it is for the cytotechnologist or for myself to really discern whether that is truly indeed representative of the radiologic findings or the image findings that are being mentioned to me about the lesion itself. So in that way, communication is the key. It is collaborative, it's transactional. So these are considerations we have to definitely keep in mind. In our practice, we introduced telepathology almost 2 years ago or so. We have a cart, which is actually a transportable cart, but our cart is actually stationed in the GI suite, and for which really eases up the process. So when we get the call, like over here, this is the front desk, and our front desk staff receive the call. They note down the details. The details are translated on a paper onto the cytotechnologist here. This is our cytotechnologist, Behzad. He's getting all the information here. Then subsequently, the cytotechnologist, in most situations, will proceed on to inform the pathologist. And this is my colleague Abba here, seated next to Behzad, who's going to go for the procedure for adequacy assessment. And they're basically what they're doing is they're looking at the clinical information, whether that tallies with what the information has been relayed initially when the call was received. Subsequent to this discussion and noting down all the details about the patient's history, which may be relevant to the case, the cytotechnologist will proceed to the gastroenterology suite. They will take the specimen, prepare the smears, and look at them under the microscope. Now, this is what we have in our system. We don't have a double-headed scope. What we have is an adjacent monitor, which can be looked at for exactly the image that the cytotechnologist is reviewing under the scope. And this is for the benefit of all whoever is present in the suite at that time. Sometimes gastroenterologists will tell you, oh, I am in the lesion, especially when you are telling them there's blood only. So this is one way for them to really equate the diagnostic findings with what they are obtaining. So this is what's going on in the suite, but with what we have is a system which is basically internet-based. This is the procedure being done here, but in my office here, this is the screen, this is the desktop, and the same image would be looked at by myself. And once I have looked at it through the help of a local internet-based iPhone, we communicate between ourselves. Of course, if the phone line is always available through other avenues, but we have our own iPhone. So this is the way we we do our adequacy assessments, because mind you, this procedure may be also going on in other locations and there's only one pathologist manning the service. So with this protocol in place, I myself can be seated in my office and look at simultaneous procedures that may involve the GI service as well as other locations. So at the time of adequacies that are being done in the GI service, for each episode or pass that is done for the aspirate, we prepare 2 slides. One is air dried, and that would be a diff quick stain on site, and the other slide is put in alcohol for subsequent staining with the Papanicolaou stain. So you take a look at these 2 examples here, and you see how the smears are done. They have almost like a head, body, and tail going on, and there's a nice way of preparing them is basically regulate your output here. If you have only about 2 drops, which you place in the upper 1/3 of the slide next to the label, and then gently smear it, this should give you the result. Basically, these should be well prepared in time and and if you are physically there with either yourself or your cytotechnologist, the material can be judiciously used for site preparation. So your next question would be, what happens to the residue in real time? We are really moving very fast between one pass to the next pass of the FNA procedure. So this is what happens. What we do is we make a clot. Whatever is extruded out of the needle, either you place it on a gauze or you can place it even on a glass slide. Don't worry about spillage. If there's a sheet of paper lying, that will catch it. But the bulk of it can be extruded out and you let it just accumulate there in such a way that after 3 or 4 procedures, this is what your output should be. And then at the end of the procedure, what you can do is that you will obtain something like a button like this. You can wrap it up in that paper that you had, the filter paper, or you can just gently slide this over in buffered formalin, and that should give you a good cell block. The cell blocks, I just want to say, are really important in our business, mainly for ancillary testing. More and more is being relied on molecular diagnostics, though not necessarily for pancreas, but for lung. But this is one good way of getting material for molecular diagnostics, or using this as a tissue repository for subsequent research work you may want to do. So we've set up a system of reporting, and it's a classification scheme, and we use as best as we can a 6-tiered system. You can also look into the Papanicolaou Society of Cytopathology guidelines. These were established in 2014-15. And again, the role of a classification scheme is to have an incorporation with a multidisciplinary approach to your FNAs. Remember, at the end of each procedure, there is a practitioner who's reading that report. So this makes it very easy for them, first of all, because each of these specific diagnostic categories can definitely correlate to biologic behavior or even risk of malignancy. So these are useful parameters for them to use for management planning. And also later on, you can always use this data for QA or even research. So for Path Society guidelines, this is a 6-tiered system. I don't want to go into more details at this point. The reference is there, and if any of you want to use it, this would be a good guideline. So we have had now about a 5-year experience with the PSC classification. What has it done really? This has been recently published by Mauro Saeg, and what we have found with this classification systems placement by this meta-analysis of different studies is that the risk of malignancy for negative category stands at 8.2%, which is a very low number. And the malignant category is, of course, extremely high at over 99%. Also, practitioners who have used this have mentioned that it has definitely helped them decrease the rate of their non-diagnostics and definitely the atypical cases. So look at the atypical numbers, which are about 6%, which is a very decent number to have as a rate of atypia for any laboratorian. So with that, let's segue into what can pose to be a big challenge. Contaminants. As you all know, it depends on where the lesion is located in the pancreas, depending on the location, whether it's in the head or the body or the tail. The gastroenterologist will use a different approach. If the lesion is in the pancreatic head or the uncinate, such as over here, the approach will be through the duodenum. So what will happen is that in some situations there would be duodenal epithelial cells, which will be present on the specimen slide. Similarly, if the lesion is towards the tail, and then what will happen is that the practitioner will use the approach through the gastric route, and that would entail gastric epithelial contaminants, which can be very difficult, especially at the time of adequacy assessments, where we are under some degree of pressure to give them some kind of an answer. So this is a low power view. Obviously, it's a very good specimen. Low power, we have a lot of cells, but there is something that you really have to look out for, is that what do these cells represent? If this is the head of the pancreas that was being attempted, this does not represent that at all. This basically is demonstrative at low power of duodenal epithelial cells. These are non-vacuolated, non-mucinous cells. These show a very nice honeycomb arrangement. But what is distinct is that within these cells are these goblet cells, and these come off as fried eggs, almost, with the central area where the nucleus is. So just again, to reiterate it, these are nice honeycomb cells, and then interspersed between these non-vacuolated cells are the goblet cells. So this is an example of duodenal cells. If you're still having difficulty, go at a higher magnification. Go to the edge of the groups. Look at the flattened cells, and this is demonstrative of a brush border, which appears as more of a fuzzy outline instead of as a sharp cytoplasmic outline. So this will again help you in confirming the duodenal epithelial contaminant. Similarly, if the lesion is in the tail of the pancreas, the route would be through the stomach. And what we would end up obtaining in some situations is gastric epithelial contaminants. These are a little bit more challenging than duodenal contaminants, because at low power, they can very much look like truly a sampling of the pancreas, which may represent a mucinous neoplasm. But what is helpful is take a look at the background. There is mucin here, but the mucin is more watery, more luminal. But the cells themselves are representing, again, honeycomb cells. They do have a mucinous arrangement, as you can see here and here. They are flat sheets, honeycomb. There is no evidence of a goblet cell population that I can identify here. And at a higher magnification, this is what you will see. Take a look at the cells here. It is basically giving you an appearance of an apical mucinous cup here, as well as over here. The cells have the nuclei placed more towards the basal area, but the superficial 1/3 of the cells is occupied by this mucinous cup. This is very distinct. So once you have this, you have your diagnosis of a gastric epithelial contaminant. The background will definitely help. Remember that if this is indeed a sampling of a mucinous neoplasm, there will be a lot more mucin in the background, which will be more thickened and more insuffated, and the cells will show you a lot more stratification of the nuclei than this nice honeycombed appearance. GI tract mucin, like I said earlier, is a very helpful clue that you're dealing with the contamination. This is an example of that. This is Disquick staining, very thin, watery appearance. Even grossly, when you make the smear, it'll have that watery appearance. In contrast, same picture here for a Disquick stained slide representing a mucinous neoplasm. Really no cells here, but this is all thick mucin. So when you have something similar to this, you know you are dealing with a neoplastic category rather than dealing with a benign, contaminant coming from the GI tract. Solid pancreatic neoplasms are going to be the bread and butter of your aspirates. Majority of them will end up being ductal carcinomas and then segueing into these other examples which represent solid pancreatic neoplasms. So with that, let me give you a case presentation, and this will have a polling question in the end. I won't go into too much description. I will leave you to review this picture in detail. This is a low power image, 69-year-old female. It's a 2.9 centimeter pancreatic mass. It's solid and has ill-defined borders. Take a look at the background, cellularity, low power view. You're doing Rose evaluation. Intermediate magnification, same thing. Start with the background, segue into the individual cell groups, whether they are clusters or flat sheets, and then look at individual cells, both within the groups as well as the ones that are spread out singly in the background. And then really, for somebody who hasn't really gotten it so far, this is a high mag view. Same process, background, and then segue into individual cell examination. And let's take a poll here. Joanne, can you open the poll for this, please?
The poll has been launched. About 10 more seconds. Close the poll. 3% gastric contamination, 2% duodenal contamination, 92% endocarcinoma, 3% acinar cell carcinoma.
Okay, thank you, Joanne. Well, you all did really well. Majority of you got the right answer. This is indeed an adenocarcinoma, and I'll go into further details after this slide, but take a look at this last image. Take a look at the cells. There's significant anisonucleosis, pleomorphism, there's cytoplasmic vacuolation, there's no granular appearance of the cytoplasm. I don't see any evidence of goblet cells here. This is not a honeycomb scenario that you are looking at for the individual cells. So this all helps in coming up with a diagnosis of ductal adenocarcinoma. For these tumors, I just want to say this is one of the most common malignancies in the United States. We have about 40,000 new cases every year. It's the fourth most common cancer in the USA, but I think that is increasing now and may overtake to become the second most common. Cigarette smoking, alcohol consumption, these are all factors which can lead towards it. But when you are dealing with a ductal adenocarcinoma, you are most likely in your practice going to see a range. The tumors can be either well differentiated, moderately differentiated, or poorly differentiated. So with that range, you are going to see a myriad of presentations on your cytoplasmic preps as far as cytomorphology goes. So that is basically what you need to learn today. Poorly differentiated, I'll start from the poorly differentiated and then segue into more moderate differentiated features. Poorly differentiated ductal carcinomas are not a problem. Low power diagnosis of a flat out malignancy significant pleomorphism, whether flat sheets or aggregates of cells which do not have any demonstrable gland formation noted within them would be the hallmark of these tumors. There'll be three-dimensionality, there'll be four-fold size variation of the nuclei from small to large nuclei. The nuclei are really large, 1.5 times the size of RBC or larger. High NC ratio and macronucleoli on Pap stain slides can be noted. Mitotic activity is frequent and very notable in these tumors, and the background is, of course, necrotic in most cases. So this is extremely easy to diagnose. This is really not going to be the problem, and this was not our test case. Our test case was more in the ballpark of what I would call moderately differentiated carcinoma. There is the presence of these disorganized sheets as well as groups of cells. And this is the disc-quick stain, again, showing you a variation in sizes and shapes of the nuclei. And again, in this disc-quick stain, you can see actually gland formation over here, along with cytoplasmic vacuolation, necrosis, and again, see the size variation in the nuclei. That would be the key at the time of Rose assessment. Similarly, on the Pap stain slide, these are two separate images. On your right-hand side, showing both groups as well as sheets, showing similar features as what you just saw on the disc-quick slides on the left-hand side. Main thing is look for the four-fold anisonucleosis and then irregular nuclear membranes, hyperchromasia, dense chromatin. All these will help you clue in onto this diagnosis. And then lastly, I have another case. This is not a polling question. This is just for me to kind of go over with you. This is a 71-year-old lady presented with a 3.5 centimeter pancreatic head mass, and that also had ill-defined borders. This is low power view. Background is relatively clean, only blood, but I do have quite a few sheets over here, and you'll have to take my word on this slide. There were many, many, many sheets similar to this. So quantitation was not an issue. And even with this power, I can see the somewhat haphazard arrangement of the nuclei here and the individual cells. What I also don't appreciate is the presence of goblet cells. So if duodenal contamination is a question, I'm relatively certain that that's not what this is. I'm indeed dealing with ductal cells, but what do they represent? This is again, same picture, slightly higher magnification. And here the isonucleosis becomes a little bit more apparent. Take a look at this nucleus, for instance, here. This is the same group. Come to this side, take a look at this nucleus here. Significant size variation, I would say a good 1:4 ratio, but this is a disc-quick stain slide. I would say this is an adequate specimen at the time of adequacy, but for diagnosis, I would still wait for looking at it at a higher magnification. And here it becomes a little bit more clearer by the presence of significant anisonucleosis. Look at the nuclear membranes here in this area. Quite a bit of irregularity is also noted there. So these are the two criteria I'm using, starting from low to high magnification to assess these groups of cells. And if I have enough groups like these, which I can say suffice for about 500 or plus cells, I would be happy with calling this adequate, and if pushed further, may even give out a diagnosis of an adenocarcinoma. But again, what do the Pap stains look like? This is what the Pap stain slides would look like. Similar features as I noted, but in well-differentiated ductal carcinoma, hypochromasia is actually more apparent, as you can note over here and here, instead of hyperchromasia. Hypochromasia, along with nuclear membrane irregularities, such as over here, indented nuclei, as well as notching that can be noted here. And sometimes you can even see longitudinal grooves. Prominent nucleoli are not a feature here. 4 times size variation is very obvious. So collectively, based on this, this would be a well-differentiated ductal and carcinoma that can be given out as a diagnosis. So sometimes well-differentiated ductal adenocarcinomas can be basically confused or have a pitfall with reactive ductal epithelial cells. So morphology, I would still say, is what I rely on for the most part for differentiating these. But if somebody really wants to work this up with immunohistochemistry, I can recommend DPC4 or SMAD4 or IMP3 or S100P positive cases. These are good markers that I can recommend. I have a reference here which basically gives you an idea of what our experience has been. So for ductal adenocarcinoma, remember that SMAD4 would be lost in about 55% of the cases. So this is essentially, if it's positive, it's nuclear, but if it's lost, that's what you would expect to see in cancer. Similarly, IMP3, which is a U3 small nucleolar ribonucleoprotein, that is basically a cytoplasmic stain as an IHC. And similarly, S100P, which is a calcium binding protein, would end up being as a positive or a nuclear stain for ductal adenocarcinoma, and vice versa would be negative for the reactive ductal cells. So this is an example here, SMAD4 or DPC4. These are the cancer cells which are negative or which demonstrate loss of SMAD4. However, the benign cells are giving you a positive here. So this would confirm your diagnosis for an adenocarcinoma. Similarly, IMP3, which I remember is a positive stain, cytoplasmic, shows you the tumor cells to have cytoplasmic staining. So use immunohistochemistry judiciously. I think the hallmark of your case should be more based on the diagnosis on the cytomorphology rather than immunohistochemistry. But if you need to rely on it, these are some of the stains which would be helpful. So some of the variants, squamous cell carcinomas, again, if you have a good sample, background will show you quite a bit of keratin, and if it's a keratinizing squamous cell carcinoma, but cells themselves, if they are cohesive on this quick stain, can give you even a basaloid appearance. Similarly, on the Pap stain slide, there would be keratinized cells along with clear-cut malignant features. Higher magnification, look at the denseness of the cytoplasm, intercellular bridges on this Pap stain slide. Similarly, the cell block shows the same features. So again, it's really not a difficult diagnosis, but the main thing is you have to remember, you have to really rule out metastases, which can come from the lung, cervix, or even from esophagus. So those are some of the things you have to really clarify clinically before calling it a squamous cell carcinoma. If diagnosis is in question, then a P40 stain, which is a nuclear stain, will confirm the diagnosis. Lastly, always remember the squamous cell carcinoma may represent an adenosquamous carcinoma, so it's a sampling issue. This is an example of squamous cell carcinoma, which over here you can see has ductal elements as well as squamous elements. Remember the squamous components, you have to look at the whole case. If it comprises approximately 30% squamous differentiation along with ductal carcinoma, then you can call it an adenosquamous carcinoma. These are rare tumors. They are part of a basal-like phenotype. Basically they may show P53 and KDM6A mutations. And again, the squamous cells in this tumor will be positive for P40. The tumors have an aggressive course, and once a diagnosis is given, patients may be hospice-bound rather than clinically managed any further. This is another very interesting case of an undifferentiated carcinoma with osteoclast-like giant cells. Really rare tumors. I've, I think, seen 3 in my career, mostly noted in female patients and elderly patients, slightly more, but literally anyone can get them. Mostly they can be found in the body and the tail of the pancreas. Usually they are not solitary diagnoses, and majority of the resections or the aspirates, there would be a component of poorly differentiated ductal adenocarcinoma admixed with this entity itself. So what do we see here? We see a 3-cell component. These are the Osteoclast-like cells, like over here. Look at the multiple nuclei there. Along with that, you would expect to see histiocyte-like small or round or almost ovoid cells. And thirdly, there will be spindle cells that can also be noted. So collectively, this is what it would look like. This is a cell block. Again, this is a subtype of an adenocarcinoma, poorly differentiated. So this is how you would give out a diagnosis based on it. Another type you may encounter, which is extremely rare, is the mucinous colloid carcinoma. Look at the upper two images. Look at the background, abundant, thick mucin. That's the hallmark, almost colloid-like. Then the cells can present themselves as floating as small, tight, three-dimensional ball-like aggregates or as flat sheets, like here. Similarly, you can also see clear-cut mucin that may be noted within these cells, as well as signet ring cells, which are also another feature of this specimen. So remember, these tumors are almost always associated with IPMNs. So clinically, look at the radiology and the workup that has been done, but if these features are there, then you can clearly give out a diagnosis of a mucinous carcinoma. Let's present our second case. For this, I will be polling you. So the history is there. 51-year-old female, 4.3 centimeters, well-circumscribed solid tumor. This is the tail of the pancreas. I'll give you a second to look at it. Take a look at the background, cell groups, individual cells. So these are the two slides representing rows. Look at the clusters, individual cells. Look at their size, shape, relationship to each other, size-wise, shape-wise. Those are the clues. And then this is, again, a representation of the PAT-stained slides, low-power view. See how vascular it is, tufting of the cells, background. And this is what the background shows. Single cells or groups of cells, size, shape, nuclear details. And then this is the cell block, low power and higher magnification. And let's get polling done on this. Joanne? Joanne, can we poll for this case? Hello? Joanne?
Momin, I'm trying to reach to her.
Okay.
I think it's on right now, but let me make sure.
Okay, thank you. Okay, Guliz, I think I'll move on. I'll just go for the discussion.
Did you see that? Joanne was able to do that. I don't know if everyone can see it, but the results are 58% pancreatic neuroendocrine neoplasm, 29% solid soda papillary neoplasm, 10% acinar cell carcinoma, and 4% pancreatic adenocarcinoma.
Excellent. That is just what I wanted to hear. You guys have done very well. This is indeed an example of a pancreatic neuroendocrine neoplasm. So these are basically called PANNs collectively. These range from well to poorly differentiated, which is very important that you recognize it, because the well differentiated ones are known as PANNets and the poorly differentiated ones are known as PANNets. And for those, there would be a small cell and a large cell category. Our case is a well differentiated pancreatic neuroendocrine tumor. So when you looked at it, first of all, at low power, you recognized how vascular the tumor was. There was an organoid pattern almost with cellular groups and clumps. Even at a higher magnification at DIFQIC, you can see there that the cells themselves have a very monotonous array. They have a plasmacytoid appearance, somewhat hint of some cytoplasmic vacuoles even are noted. So that is basically a hallmark of this tumor. These are very fragile cells, very low mitotic activity. There is no granularity to the cytoplasm. There is a plasmacytoid appearance certainly, but no discernible granularity, in my opinion at least, that you can notice. The cells, when you look at them at the PAP stain slide, they have that classic salt and pepper chromatin with small and distinct nucleoli, but some cases they can also be prominent. So this is the range that you would expect to see in pancreatic neuroendocrine tumors. And then this is again a view of low power view of the cell groups illustrating the vascularity, but there's no myxoid elements here, so that kind of excludes an SPN or a solid pseudopapillary tumor, and also the presence of rosettes are very helpful in completing our diagnosis. But obviously, without neuroendocrine stains, I personally would not sign them out. I would recommend do a synaptophysin stain. It has really stood the, it has withstood the test of time. Nice, robust staining, as can be noted in our example. Another new stain that we have validated recently is the insulinoma-associated protein 1, which is INSM1. It's a nuclear stain, and that I can recommend, has a very high sensitivity as well. Similarly, remember these tumors, there is a loss of DAX and ATRX protein, so that can, if you can translate that into an IHC stain, which are available, that can also be done, and those would present as loss of staining, especially in the nucleus. Lastly, these tumors require Ki67 staining, which can be helpful for grading. This is a low power view, mainly look at the cell block. Plenty of cells here, very cellular specimen, and then this is a very low percentage of Ki67 that you can notice here on the Ki60 on the stain. So this confirms the diagnosis. How do you calculate it? First of all, you have to have a good sample. You have to have a lot of cells on your cell block. I would recommend do a manual count. What you can do is take a photograph of a selected area or two areas and then manually count 500 cells if you have them. Mainly this is to exclude lymphocytes from falsely being counted as part of your tumor. This we have encountered previously with image analysis, so this will help you in confirming the diagnosis without any pitfalls. This is the WHO classification of how to grade them. It is helpful to grade your cytology FNAs, but remember you have to put it in your note that this grading may change if the patient undergoes surgery and a Whipple is done or some kind of a resection is performed. So these numbers may change, but this is how you would approach your grading system with the mitotic indexes or Ki67 proliferation index right here. So pancreatic neuroendocrine carcinoma is very similar to what you might have seen in the lung. You can find small cells and large cell neuroendocrine carcinoma showing you characteristic nuclear molding, crush artifact, and positivity in more than 50% of the cases with neuroendocrine markers such as synaptophysin. That will definitely help. Remember, these are mitotically active, so a lot of mitotic activity would be noted with the tumor cells. Also, background may end up being very necrotic, so that can also be a problem while procuring a good sample if you don't have enough viable cells. So then you have to get additional samples to confirm the diagnosis. Moving on to acinar cell carcinoma, this is very much in the differential diagnosis of especially well-differentiated neuroendocrine carcinomas, but these tumors, they are a little different. Again, they are rare, but what you can really expect to see is the age. The range is in the 60s, males more than females, and These tumors are generally large at the time of diagnosis, and this is what you see at low power. Remember, this is basically giving you a very good example of almost acinar-like configuration rather than cells which have an organoid pattern. Very similar cell background is rather clean here, and this is the cell block, same configuration, very hypercellular sample, which are characteristic acinar-like cells, and they lack other elements such as ductal elements, admix, which confirms that indeed the tumor itself has been sampled. The cells are larger than normal acini. That's another clue there. Remember, the cytoplasm has this granularity, and those are zymogen granules. And on path stain, they can give you this very classic red appearance. So this is what would help you. Also remember, how do you exclude these just on eyeballing these cases from neuroendocrine tumors is presence of mitotic activity. These tumors will be highly mitotically active in contrast to well-differentiated neuroendocrine tumors. So that will definitely help you in confirming the diagnostic impression, especially on low power, even at the time of adequacy. How to confirm it? You can do a trypsin stain. If you don't have that, then a BCL10 is usually positive, even in trypsin negative cases. And these two markers I can recommend. What I do want to point out is do not do an alpha-1 antitrypsin. That is not a marker for this cancer to confirm its diagnosis. Secondary pancreatic neoplasms, these do come into play. You should be aware of them. Metastases to the pancreas is very common. And there's a very good study from 2017 from the University of Hawaii, which I can recommend. But furthermore, recent IACM has also presented us with a smaller number of cases, more recently in cytopathology for your review. But by and large, with all this experience that these publications have shared with us, is that most of these cancers, these are solitary lesions. So again, a pitfall, that's something you have to realize. Most of them occur in the head of the pancreas. The size can really range from 1 to almost 11 centimeters. So think of it, solitary lesion, head of pancreas, really large. That's what you've been requested to aspirate, and then it looks like an adenocarcinoma. So you have to be really conversant with the patient's history. If you have any questions, then confirm it by stains, whatever is relevant to the presentation. But remember, lung cancer, whether an adenocarcinoma or neuroendocrine carcinomas, would be the main tumors that you would encounter, along with renal cell carcinoma, the clear cell type. Those are the most common ones that you would encounter in your practice. So if you haven't seen one, expect to see some sometime in your career. Pancreatic cystic lesions, again, remember, most of these, if they are neoplasms, would end up being intraductal papillary mucinous neoplasms or IPMNs. However, the majority of these tumors are non-neoplastic. And when they are non-neoplastic, what are you going to find? Most cases will be pancreatic pseudocysts, majority of them. So basically, the main goal of aspirations, if radiologically it's a cystic lesion, is to distinguish whether these lesions fall in a low-risk category, meaning medical management, or a high-risk pancreatic cyst, which may or may not be surgically bound for surgical management. So that is basically the question. If you have that premise in mind, you can easily stratify them into low-risk pancreatic cysts, which would include pseudocysts, serous adenomas, lymphoepithelial cysts. High-risk cysts are, as expected, can be IPMNs or MCNs, which have a high incidence of harboring malignancies, such as an accompanying adenocarcinoma. So ancillary studies are very important. Remember, you can collect for enzymatic analysis. You can visually look at it for viscosity demonstration as to what it looks like, and then other markers are very helpful. Amylase is very important. Remember, if it's a non-neoplastic cyst, it will be high. For neoplastic cysts, it will be low. One point I want to make over here that IPMNs can show you a high level of amylase. So viscosity, remember non-mucinous cyst, viscosity would be less than what serum would feel like when you make a smear, and mucinous cyst, it would be very viscous. Similarly, tumor markers such as CEA, non-mucinous cyst, not elevated, and for elevated mucinous cysts such as IPMNs, this is the cutoff, that is 192 nanograms. But remember, this is lab dependent, and you can validate your own specimen, then the number for that may be much lower than this published number of 192 nanograms. So pancreatic pseudocyst, remember, turbid fluid will be aspirated. As you can see, this is all just very granular appearing background in this aspirate with some macrophages in the background, some granulation tissue. Similarly, this is the cell block giving you a very nice example of what a granular background with macrophages, both having pigment within them, as well as granulation tissue in the background. Higher magnification over here, this is what pigment looks like, which can be brown or yellow depending on what kind of pigment it is. This is basically just free floating here, the pigment. No viable epithelial cells are noted. And remember, these will be amylase-rich aspirates. Field of cyst adenomas, the radiology is the key over here. Very classic appearance, multiloculated, soap bubble, mostly in the body of the pancreas, central scarring, calcification. These have an excellent prognosis. So for these, the sample that is obtained is usually thin and clear, unlike the turbid fluid that was noted in the pseudocyst. And most of these cases end up being very hypocellular, and which makes them being signed out as non-diagnostic. So keep an eye on that. Look at the radiologic picture, ask for more samples if you need. And this is what you would obtain if you do indeed get cells. Want to basically point out, this is a flat sheet, not on edge, but basically on false placement of polygonal or round cells. Clear cytoplasm, which is showing you glycogen-rich elements here. It will be PAS positive. Similarly, on histology, you would see dilated cyst-like spaces. A gross picture here showing you central scarring, extended spaces, cuboidal cells, clear cytoplasm. This is glycogen here. Lymphoepithelial cyst, the name itself gives you an answer for anyone. I mean, this is basically a benign diagnosis, and that's why they want to really rule in or rule out cancer, and that's why these are aspirated. But when a sample is obtained, predominantly you'll end up getting quite a bit of nucleated squamous cells with not much marked atypia, along with anucleate squames, macrophages, and then lymphocytes. And along with that, if there is inflammation, there might be some acute inflammation also noted. So main thing is, if the diagnosis is rendered, it obviates the need for any surgery. But if this lesion is large, then it might end up being surgically operated. Pancreatic mucinous neoplasms, two main diagnoses here, mucinous cystic neoplasm or the intraductal papillary mucinous neoplasm, or the IPMN. They are very similar in appearance, but let's just go over them. This is histology here. Mucinous cystic neoplasm, this is generally a single layer of cells, columnar cells, basally placed nuclei, underlying ovarian type stroma, but the layer itself is flat. There's no stratification going on. As you can note, no papillary projections or villus-like projections. In contrast, this is an IPMN. Again, this is a single layer of columnar cells, basally placed nuclei, abundant mucin, as you can see over here, and they form these nice projections which kind of project upwards here. So very different from the MCNs, and there's no underlying ovarian stroma. So these are some of the key differences. You can review them at your leisure in your handout, but main thing I want to flag out is please review the Sendai and the Fukuoka consensus guidelines for management, because most of the time these end up being discussed at tumor boards, and if you have a working knowledge of these guidelines, they will help you in determining what a high risk or worrisome features would look like in these lesions, and especially in the IPMNs. Mainly the size criteria is 3 centimeters, but I have seen cases which have been smaller than that, showing an adenocarcinoma in accompaniment with the IPMN. This is what the specimen would look like. Really on cytology, you really cannot separate the two of them. When you aspirate either of them, you will end up getting abundant thick mucin, as you can see over here. This is Diffquick. This is a thin preparation over here with the Papanicolaou staining, where you still see the almost thick mucin. And these are the cells themselves. See how basally the nuclei are placed in this layer of columnar cells with mucin lining the cells as well. And then these cells are floating in a background of mucin. Again, very bland appearing cells, so there is no atypia noted here. So there is not much clear distinction between MCN and IPMNs on cytology. They would show the cells themselves as columnar cells with abundant intracytoplasmic mucin. Now here comes the question of can we really separate them? I just tend not to, because it's a very difficult exercise, but if you find papillary clusters such as this, as you note over here, then you can lean towards a diagnosis of an IPMN. Similarly, phammomatous calcifications, as you see over here, are more likely to be noted in an IPMN. So these can lean towards a diagnosis rather than completely confirm it. So basically, these are some elements which can help you separate the two, but again, it is perfectly acceptable to call it a mucinous cystic neoplasm on your final diagnosis if you cannot separate the two. The next question is atypia. So atypia and these mucinous neoplasms, both of them, what you need to do is you have to characterize this as either a low grade or high grade. Low grade atypia basically is slight sway away from the norm that you have noted in these cells. It would be slight more nuclear crowding, some loss of polarity, slight hyperchromasia, and a slight increase in high NC ratios. But those cases are mostly medically managed and do not end up being surgically operated on. It is the question about high-grade dysplasia that comes into further discussion as far as surgical management goes. And the best way to give you an answer as to whether there is high-grade dysplasia or not, look for these smaller cells with high NC ratio, hyperchromatic nuclei. If they are grouped together, you can actually really observe them even at low power. In a background of necrosis over there, this is basically going to confirm your high-grade dysplasia. If you can find some contaminants such as duodenal epithelium, look at the duodenal enterocyte and compare the size with these cells. These are the same size as those cells, about 12 microns. So if that is your benchmark, you will be able to identify them easily. These two images in the lower column over here, these are cell blocks, similarly showing you the stuffed of high-grade dysplastic cells over here, showing you the features that are noted here on the thin prep, which are in the upper column and the inset picture. IPMNs, a few caveats, not all are classically mucinous. There are 4 types. Remember that. No one would want you to subtype them, but remember that the pancreaticobiliary as well as oncocytic IPMNs have less mucin, and mostly the intestinal and the gastric types would be the ones that would have the classic presentation, which I've shown you. IPMNs, the oncocytic type, that has been put into a separate category now completely, and these are somewhat vascular with fibrovascular cores, dense granular cytoplasm. Main thing is that they have a very distinct molecular alterations such as GNAS mutation, and these have a better prognosis. But the numbers of these are in the literature, especially the cytology literature, very few. So as far as prognosis goes, I think it's still a work in progress, and we will know better in a few more years when more publications are out there about prognosis. So this is a brief overview of how to manage these. And again, the question is there high-grade atypia or not? That is the main question your surgeon wants to know from you. So, and that's what you need to diagnose. Some last words here. I've already gone through them. If you can't separate the two categories of MCN or IPMNs, call them neoplastic cells, and then you can call them mucinous neoplasms. So let's go over a class bonus case. There is no polling on this. Case number 3, 42-year-old lady, well circumscribed, 2.8 centimeter, tail of the pancreas mass. It's solid and cystic as well. Low power view, and here you can see it's very cellular. It has quite a bit of vascularity, as you can note over here. The cells themselves are mostly polygonal or round. They do show a variation in size, but not too much as far as shape goes. But the clue over here is take a look at the elements over here, which stand out as slightly being more pinkish. And this is the corresponding path. So remember here, this is magenta colored myxoid stroma on the Diffquick. And similarly on pap stained slide, here this is bluish gray myxoid stroma. The cells themselves are somewhat uniform. There is slight size variation, but by and large, they're giving you that very classic appearance of a solid pseudopapillary neoplasm. This is really a high magnification, where you can see the fibrovascular core. The cells themselves are mostly oval. They have longitudinal grooves. The chromatin is somewhat clear or vesicular nuclei, as you would call it. Powdery chromatin. Nucleoli are not very prominent, so this is really how you would diagnose them. The staining that I would recommend is a beta-catenin. It's a nuclear stain, and that should confirm your diagnosis. Remember, these tumors can, in about 20% of cases, be positive for synaptophysin or other neuroendocrine markers. So it's a known pitfall. So look at the case carefully and don't make that mistake, please. Remember, mitotic activity is also another helpful key here. These will be slightly little bit more mitotically active than a low-grade or a low-grade pancreatic neuroendocrine neoplasm. So in summation, and the time is almost up, FNAs are being complemented with larger bore specimens like core biopsies, so ProCore or SHARCore, depending on your institution. Quite a few of these are being used in a variety of clinical settings, but I'm always welcoming additional material if possible. Keep some of this material and process this as a cell block, and this will all help you and complement your FNA and render a more definitive diagnosis. So with that, thank you for your time. I hope you have all learned. I hope to answer some of your questions this afternoon, but if not, then please email me, or you can always contact me through other channels, Twitter being one. Thank you. With that, I conclude.
Well, thank you very much. That was a fantastic overview of pancreatic pathology, which sometimes could be difficult, and we all end up scratching our heads about some of these cases. I do see there's some questions from the audience, and I'll read them to you. One of the questions are, what are the criteria for an adequate sample? In other words, what is the adequacy criteria for pancreatic pathology?
Good question, Gulis. Thank you. So if we are dealing with a malignancy that's suspected based on radiologic considerations, then look for at least, I would say, 100 cells on your diff-quick stain at the time of adequacy assessment. I think that really is a good metric. Less than that, obviously, people can and do make diagnoses based on that. But again, definitely well-differentiated tumors and known pitfalls, it's good to have a good quantitation. But for me, I know it might not be evident in literature as far as the exact number, but I would say 10 cells or 10 groups of clearly malignant cells, whether well differentiated or more poorly differentiated, that should be enough. And then additional sampling for a cell block is always good.
And then just a corollary to that, for the cystic lesions, they typically don't do a rapid on-site evaluation. But if they do that, there probably isn't any guidelines for the number of cells or the mucus in the background or the mucin in the background, correct?
That will be correct, Guliz. I think if you have thick gelatinous mucin, gross evaluation and on diff-quick sampling or staining, then that would be a consideration for calling it adequate.
Mm-hmm. Another question from the audience: how can we differentiate the gastric or duodenal contaminants from gastric or pancreatic heterotopia?
Good question. That would be a very difficult diagnosis, I would say. And I would say for that, clinical correlation is your best bet.
That's a tough one. Yeah, I have no idea. What type of transport media do you have on your ROSE cart? What do you do for culture and flow submission?
Okay, so for RPMI, we do have access to a fridge in the area. If not, then if it is suspected that there would be a lymphoma workup, we take it with us downstairs to the GI suite. So for lymphoma workup, RPMI, depending on the situation, we will take it with us. We do have, for microbiology, we just collect fresh, that's all, and then submit it directly.
All right.
If you don't want to do that, you can put it in saline. Slide.
Now, another question is about the IMP3, the immunohistochemical stain. Is it helpful for all pancreatic lesions? Are they positive and, say, well-differentiated versus poorly differentiated carcinomas?
So the question about well, moderate, or poorly differentiated ductal carcinomas, I think it depends on the institution and your clinician. Some places they do want that, and I think I've given you sufficient criteria today. But in my practice, I just tend to sign them out as an adenocarcinoma and do not try to further characterize them. However, for neuroendocrine tumors, I think it's always a good policy to attempt to further characterize them based on the differentiation, because management based on the size itself may change. They may want to watch and observe it rather than surgically remove the lesion if it is very small.
Now, there's another immunohistochemical question about MASPIN this time. Have you ever encountered MASPIN positive reactive pancreatic ductal cells?
No, we have not used it at all. I mean, and I would say not many people are using it as a clinical marker. The most prevalent ones are SMAD4, IMP3, S100P. Those would be the main ones currently used by most, large institutions. From what I have chatted with our nationally here. But MAPSIN, I don't use it, so I don't have an experience, and I cannot really, tell you about what its sensitivity or specificity would be in separating malignancy from benign cells.
Okay. Another question, more of a morphology question: how to differentiate between colloid carcinoma and gastrointestinal contamination? You mentioned the mucin, watery mucin versus the thick mucin. Is there anything else?
I would say look at the cells, starting with the background. Like I said, it would be a really thick, abundant layer of mucin, stain would be dark on the Disquick stain. And then the cells themselves would be more three-dimensional ball-like aggregates. Those would be the norm for a mucinous carcinoma. The contaminant themselves, they generally come off as sheets. They don't really ball up. But remember, mucinous cancers can also have those sheets. But main thing is there will be a lot more mucin in these cells than the gastric contaminant. The gastric contaminant cells would be very monotonous. The basally placed nuclei, if you find them on edge, and then only the superficial 1/3 has that cupping area of mucin, not extending further down into the cell itself. So that's basically the clue. I would really use that as my benchmark.
There's a couple of questions about neuroendocrine tumors. Seems like this was a tougher area. Question is, do you grade the neuroendocrine tumors on FNA? Do you feel comfortable? Do you use the cell block for Ki67 for grading the neuroendocrine tumors? And also how to differentiate grade 3 PanNet with pancreatic neuroendocrine carcinoma?
Okay, I feel very comfortable in grading these tumors. I think we need to be promoters of grading, and for that, I think the work actually starts at the time of procurement and adequacy assessment, that our focus needs to be driven towards getting a good cell block, because that's the formalin fixed issue that has been validated for Ki67 indexing for our institution. So basically, that's what I would drive at. I would be very comfortable if I have quite a few groups of cells. And then how would I separate this grade with the G3 well differentiated from, say, the from more high-grade tumors? Remember, the cells themselves are rather bland appearing in the G3s, well differentiated, but only the mitotic activity and Ki67 is very high. In contrast, the high grades are classic small cells or large cells, neuroendocrine carcinomas. I know the values of Ki67 may be similar, but the only difference being the morphology. The low grades still look like low grades, but only the mitotic numbers are high.
Yeah, these are difficult ones, yes. Another question about differentiating IPMN and mucinous-cystic neoplasms on cytology. We typically don't, and it's difficult on cytology, but can you use immunohistochemical panels to differentiate between these two, and do you?
You know, there's ample literature, especially in the surgical pathology realm, about MUC1 going all the way to MUC6. Those are stains. Not many places have those stains available. We don't in our institution. And and it's like 6 stains, you do them together and then have a grid as to what comes back positive, negative, and then based on that. However, answer is I would not use those stains. I would personally not use stains in cytology. More on a biopsy or a resection specimen is what they should be used for. The other thing is the difference between NCN and IPMN is the subepithelial stroma in the NCN, which are ER/PR positive. However, I have yet to see any of that stromal material on my cell block material ever. So that's another that one can use if you have something that looks like ovarian type stromal material on your cell block.
Another question about the cyst fluid analysis. And the question is, do you wait for the cyst fluid analysis results before signing out a pancreatic cyst FNA?
In an ideal world, I would, but ours are a send-out test. Currently, we are trying to validate them locally, but till that time, these are send-out tests, so it takes about 2 weeks to get an answer sometimes. So answer is no, I'm not waiting for them. But I would highly recommend that.
Yeah, and most of the time, those cyst fluid analysis is back in a day or so, when the FNA is ready. So
Exactly, yeah.
Calls over the weekend or something, but another question about what is the utility of CK17 in the diagnosis of ductal adenocarcinoma. I wonder if they meant CK7, or is there a CK17 that I don't know of?
I would not use it. I think some studies have shown some positive results, but at the same time, I don't think cytokeratins are the way to go about diagnosing pancreatic ductal carcinoma.
Mm-hmm.
CK9 is the main one, actually, yeah.
Another question is, in some institutions, the cores are replacing FNAs. And is there a future for EUS-guided FNAs?
Oh, absolutely, yes. I mean, I think it's, remember, I mean, pancreatic pathology itself, whether cyto or search path or both together, it's a multi-modality approach now. I mean, I'll share this with you that our weekly pancreas tumor board, cytology really drives it. And along with search path, but I mean, we are really very much a partners with our oncologists, our gastroenterologists, and our GI surgeons there. So there is a future for it. Absolutely. I think one thing definitely correlates with the other, and the more material one has, the better it is for the patient outcome. It's a one-step process when you go to collect the specimen. I mean, for adequacy assessment, the FNA followed by concurrent biopsy. I mean, that's basically what's going on now. And the material that we are given sometimes is actually the core biopsy itself, because sometimes the lesions are so small that they are not amenable to be submitted to surgical pathology as a biopsy, and they end up being given to us as a cytology specimen.
Mm-hmm. Yeah, this actually, if I may chime in, the American Society of Cytopathology is actually working on this, on the small biopsies, and recently a survey went out to the membership to see what percentage of cytopathologists actually sign out these core needle biopsies, and there's currently being work on that, hopefully which will result in a white paper coming up, with the main premise being, as cytopathologists, we're in the forefront of all this, and even if they turn into core biopsies, maybe there are touch imprints, or even if they're not, it would be ideal to have a one-stop shop rather than the core needle biopsy being signed out by somebody other than the person who signs out the FNA, which then ends up with two different diagnoses sometimes, and that confuses the patients and the clinicians. So the idea is to avoid something like this, hopefully going forward.
Yeah, I'm really in favor of, yeah.
All right. Maybe I'll take one last question. We're getting about 20 minutes late. Last question is, what's the discrepancy rate in grading pancreatic neuroendocrine tumors on cell blocks versus the subsequent resection? In the sense, are they upgraded, downgraded, or are they the same compared to the cell block material, just because it's a small sample?
I think I don't have any definitive data in front of me right now, but anecdotally, we have had matches, complete one-on-one basis, between cytology and biopsy or resections at Cornell.
Okay. So ideally, it should be, like you said, maybe take a picture of the cell block and then do your counting on the Ki67 and grade it accordingly, is what you're saying. Based on
and I would advise people not to submit it for image analysis because, again, computer-generated programs can really overcount. So something low grade will end up being called as a higher Ki67 index than it actually is. The lymphocytes tend to light up, and that's what machine-based imaging can really lead to false positives.
Mm-hmm. All right. I said that was the last, but there's a couple of other questions.
Sure.
Liquid-based preparations, since there's a couple on the same area, if you don't mind me asking.
Not at all.
The participants are wondering, what is your experience? Say for instance, they are in a lab and they get sent out from a hospital 20 miles down the road, and all you have is these liquid-based preparations. Can we still make diagnosis on these? Can we still grade these? Any tips, suggestions? What is your experience?
So let me get this right. So somebody is off-site in a different location and they are given a specimen and all they have is, say, for Cytolite for thin prep. Is that what the question is?
Right. All they have is Cytolite for thin prep, which, you may be able to do a cell block, although it will be...
Right. So I would say collect as much as you can at the time of procedure. If it's a solid lesion, certainly you can put it all in there, but make sure you get at least 3 or 4 passes. If it's a cyst, then that makes it easy. You can submit all of it for thin prep, and then subsequently you can prepare one thin prep slide out of it. And if there's residue left, and then that can go in for a cell block preparation. So that was what I would recommend. And I think for cysts, that's basically the route we have gone here for the most part.
Yes.
Because remember, the GI service operates on its own schedule for a variety of reasons. They may be doing these procedures and they may find incidental pancreatic cysts, which they were not in there necessarily to detect or diagnose, but then they see them and they end up aspirating them at all hours when our service may not be available. Then what they do is for these small cysts, they just aspirate them and they send them in Cytolite to us. And we prepare a step one slide, and if there's more material, then definitely a cell block can be attempted on it.
Sounds wonderful. Well, thank you very much for answering all those questions, and thank you for this fabulous lecture. We really appreciate it, and I'm sure all the participants really appreciate you taking the time to give this too. So for everyone, let's meet again this time next week. Next week, we will be talking about thyroid cytopathology with Dr. Syed Ali. And till then, stay safe.